Okay, when I left off yesterday with diaphragmatic hernias, all of what I talked about yesterday was special cases, special patient factors, special surgeries. Um, but now we'll talk about when an arrest or an anesthetic emergency happens. Um, so, what is our role? Obviously, we play a huge part in initiating resuscitation. Um, and one thing that's recommended, and some clinics do this, is do a role play, have a stuffed animal, um, and initiate a scenario. And everybody should know their role. I'm going to talk about like things you need to do first because that might determine what is the first thing you do, what is your role. And so the other thing that we have to worry about when you're in a general practice and you have, a complex surgery or you have an emergency with a patient, does your clinic have after hours capability? Um, Usually most general practices have a certain emergency clinic that they use, like VCA where I am at. If we had an emergency, we have 24/7 care, and an ER and intensive care. So there was a lot of times, like if I was on ER, that we'd get a case transferred at 7 p.m. like it had been at the vet during the day, something didn't go well, and they would just send it to us for overnight monitoring. So it didn't come on an emergency, but often, and then the owner is responsible for transport. So you also have to make sure if something like this happens, the owners are willing to bring the animal over. Occasionally, I've done this maybe once or twice. I've offered to transport an animal for an owner to help them out. So, like I said, it's not that the owner absolutely has to come, but all of this has to be communicated because I will also tell you, you have these advanced surgeries, you have these emergencies, intensive care and after hours care is expensive. So the owner also has to be aware that they're going to incur an extra charge by having to go to an intensive care unit or an emergency hospital for the evening. So, and most emergency practices are 24/7. When I was in Chicago, actually, when I worked at a general practice, I used to pick up some weekends, and there was an emergency practice that was just weeknights. So we opened at like 6 p.m. and we would close at 7 a.m. and all those cases had to go back to their clinics. I didn't really like that because there's some cases that I'm like, people are transporting post-op GDVs and traumas, in their own car. But it was just a small overnight hospital to help local veterinarians with their overnight care. So just make sure you get all of this in writing, how much estimates cost, because I have also had clients come in and they were like, oh, I thought this was part of our charge from the other hospital. They were not supposedly given an estimate. And that becomes a very frustrating situation for your client and for us, because then I hand them an estimate that says, $1,000 for overnight care, and they weren't expecting that. So make sure everybody is ready, that they know what to do. One thing too is when we think we have a problem, when we think we have an emergency, you have to think through it. Now, you can't sit there and dwell for 5 minutes and go, But if again, your crash cart should always be checked and ready to go. What normally we do, and you'll see this in surgery, is they have tackle boxes. They look like big fishing tackle boxes, and usually they are inventoried at least monthly. And then whoever inventories it puts the date and their initials, and then a piece of tape goes over the box. If you have an emergency, we crack the tape, and I may just remove one syringe and one bottle, but if that tape is cracked, then someone else has to inventory it, tape it with the date. This way we know, like if I grab that box and the tape is not torn, then I know that box should have everything in there that I need. And then I have the initials of the person that checked it if there's something that's not in there. But if I see a box with somebody's initials and it's taped, and usually our crash carts at BCA, we used to keep a big piece of tape across the drawer. So we had like a big rolling cart, and it had dates and initials. The other thing is, you know, as soon as you are concerned that there's an emergency, as soon as you are suspecting, you definitely want to alert your doctor immediately. And you say, hey, I think something's wrong here. I need you to look at this. I need you to check me, because you don't want to be unsure. And the other thing is, what's really recommended after you have an emergency of this nature is to have a follow-up discussion. Because, and we called, when I was at Purdue, anytime there was a case that went bad, we did something called morbidity and mortality rounds. So we would all meet in a room, doctors and technicians, surgeons and anesthetists, anesthesiologists, and we would talk through the case. And it gets uncomfortable for people because it seems like it's a point fingers, but really you're trying to identify, is there anything we could have done different? Is there anything I can learn from this? If you don't discuss it, if you just sweep it under the rug, nobody learns from that situation. And again, a lot of times, you know, if it happens, it happens, but sometimes we do discover that a mistake was made. And sometimes that sets up new protocols, checklists, training. So, you know, that's definitely something that should be done, is you really should look at the case afterwards. So what are some common problems that we encounter during anesthesia? Now, sometimes we have a patient that won't stay under. Now, one of the issues they had, that neuter that died recently, and he was a little bit older, he was cryptorchid, so, you know, they honestly think he maybe had some underlying heart disease, but he was having a hard time staying down, staying anesthetized. Now, that can be, we didn't give them enough pain meds, and the gas isn't enough to keep them to sleep. But, you know, one goal for you guys in surgery is to keep your patient somewhere between 1.5% and 2.5%. When you get up to 3% and higher, that's a significant amount of ISO. Now, ISO is a fairly safe drug, but when you start getting above 2.5% and 3% ISO, you start to see hypoventilation, hypotension, sometimes bradycardia, but if they become too hypotensive, you can see tachycardia from low blood pressure. They're going to vasodilate, they're going to get colder. So my goal is always, I try to stay in that 1.5% and to 2.5%. And maybe the dog needs more pain meds. Maybe we need to give them another, an injection of butorphanol if we can't keep them asleep. On the flip side, if you turn them up and they get cold, or you leave them up too long, like sometimes an animal gets light, they start kind of moving, you turn them up, and then you get busy, and then you forget that you still have them on 3-4%. I mean, if I turn them up to 5%, that's got to be pretty extreme. I'll probably give them propofol before I turn them up to 5%. But, 5 is a pretty high percentage to be on. But then you got to get them out of it. And the quickest way to do that is to turn them down. And sometimes I turn them down pretty rapidly. But let's go through some of these. I guess I'm talking through and then missing some of these slides. So if they're not asleep, you may have them too low. Maybe the vaporizer wasn't filled. The tube can be blocked. Also, if your endotracheal tube is leaking, and sometimes you don't smell gas right away, but if gas is leaking out of the cuff, then they're not going to stay asleep. If they stop breathing or they're not breathing deep enough, then they don't take in the gas and they don't stay asleep. So are they hypoventilating? Where hypoventilation is either too little of breaths or too shallow. And that tends to be the rapid, shallow breathing, obese, the little toy patients tend to do these little choppy breaths and they don't take in enough gas. Or did we set up the machine wrong? So if we're gonna say, how do I respond to that? Check your vaporizer, make sure that you have. Sometimes people forget to check the vaporizer, and I've had patients getting light and the vaporizer was empty. Nobody checked it. So make sure there's agent in your vaporizer. Make sure that all your tubing is connected. Make sure your endotracheal tube is connected to the Y piece and it's not kinked. And then smell. What you do is you bag the patient, and if you hear like gas escape out of the mouth, then you know you have to re-inflate your cuff. Then you have a leaky tube. And the other thing is, remember, you also want to check your heart rate, your respiration, your blood pressure. If the patient is truly light, the heart rate's probably going to be faster, respiration's probably going to be faster, blood pressure's probably going to be higher. And if all else fails, if you keep checking everything, if we truly think, say somebody dropped that machine and the vaporizer isn't delivering the proper amount of anesthetic, then you may have to switch machines. I mean, that's my last resort. Usually by doing any of the other stuff, you can fix it. And like I said, if I have a patient that won't stay asleep, sometimes I give them a little butorphanol or morphine or whatever opioid they had as a pre-med. Sometimes they just need more. Sometimes we just didn't give them enough and they hurt. Now, some signs that they are too deep, and this is where you have to really be cautious that you don't have them too deep. Like I said, 8 breaths a minute is fairly slow for anesthesia. When they start getting down to 6 breaths a minute, they are pretty respiratory depressed. Now, I've had patients that hover between 6 and 8 breaths a minute, and I like their blood pressure, their heart rate's good, jaw tone, like everything else looks fine. And some patients do have a slower respiratory rate. But when you get to 6 and 8, you got to be looking at your eye position, check your jaw tone, okay? Check their temperature, check their blood. We got to start looking, is anything else going in the direction? Sometimes when they're too deep, they get pale or they get that extended capillary refill time, because normally what happens when they're too deep, their blood pressure drops, and then when they have a low blood pressure, they don't have adequate perfusion, which can lead to an extended capillary refill time. And bradycardia, and again, I can't say this enough, there's 2 forms of bradycardia. There's the heart rate that was 120 in the prep room, and it went to like 110, then 106, then 92, then 84, and this is like every 5 minutes, like you're checking it every 5 minutes, and it's kind of doing this gradual slope. When I start to see that gradual slope, I'm like, well, they're getting deeper, they're getting colder, I'm going to probably try and turn them down, and then sometimes they will plateau. But if they keep going down this gradual slope, that's telling me that they're probably getting deep. Now, if you have a drug like dexdomitor, you're usually going to see a pretty low heart rate right off the bat once the pre-meds kick in. You're not going to see, and hopefully you guys are seeing this because you guys are using dexdomitor in radiology, so you guys should be familiar. But if you have a heart rate of 120 at 1 5-minute mark, and then you get it 60, normally doesn't drop off a cliff. And that can be vagal stimulation when you get a very fast drop. And again, bradycardia that's gradual, the way I treat that is I turn down the anesthetic. If I have a massive drop off a cliff, drop in heart rate, we're probably getting atropine, or if it's dexdomitor, maybe reversing them. You know, it kind of depends on the situation. If we have, now your blood pressure values, generally your systolic should always be above 100 and your mean should be above 60. When you're getting down to 80, which is your top number for systolic, that's getting pretty low. We really want to keep that at 100, and you really want to keep your mean at 60. So your mean shouldn't go below 60. And if that's dropping, that's another sign your animal's too deep. You may see some Brady arrhythmias, some second-degree heart block, first-degree heart block, and their temperature. Now, when we start to get different people, I am not as nervous about hypothermia under anesthesia. I've seen some pretty low numbers. But when you start getting, I think, below 98, 97, 96 degrees, they're getting pretty cold, and their anesthetic need decreases. Hypothermia decreases their need. Everybody needs to know that. So the colder my patient is, I should be turning my patient down as they're getting colder. One thing that we want to look for is that if they're too deep, they usually have no reflexes, very flaccid muscle tone. And one thing is central eye position. It's not on here. Dilated pupils, lack of a pupillary light reflex. Now, when you shine the light to check for a pupillary light reflex, under anesthesia, it's going to be delayed, but they should still have a pupillary reflex. It may be sluggish, and that's normal. But if it's absolutely gone, and their eyes are central, and they're not blinking, do you see the picture that's being painted? Low respiration, bradycardia, drop in blood pressure, central eye position, dilated pupils, no blinking, no pedal reflex. Everything is screaming at you going, everything is kind of shutting down and is very deep. And flaccid muscle tone means their jaw, their legs, there's like no pedal reflex. The jaw is just like flapping in the wind. Very, very deep. And again, sometimes this happens because we gave too much isoflurane, which would be an overdose. You have too much going to the patient. It could be that the patient has a medical condition, or that they are just too cold. If they're too cold and you are not turning them down, they are going to get deep. So the first thing you got to do is you got to decrease the vaporizer. I have been at times so concerned, I almost turn the patient off. I want to get as much ISO out of their system. And then if they get light, I can always turn them up. But I'd rather really crank it down. If I really am concerned, like they're like on the verge of arrest, like they're very, very deep, I will turn the vaporizer off. I will disconnect the patient and I will hit the flush valve to get any anesthetic out of the tubing. And then I will start bagging them with pure oxygen. Because what am I doing? I'm flushing the lungs. I'm trying to flush out any anesthetic out of the patient. So, but if you leave the vaporizer on and you start bagging them, you're going to bag them too deep. So you may have to do this. Now, one thing we can do is you've got the heating pads. You have IV fluids. If we're really concerned they're deep, can we reverse anything? If you used morphine, you can use Narcan. If you use dexmedetomidine, you can use antecedent. So do you have a reversible drug on board? Reverse them. When that neuter arrested, he got antecedent because he had been pre-meded with dexmedetomidine or dexdomitor. So he was reversed. Now, doxapram is a respiratory stimulant. It is not, I've already mentioned it a couple times in lecture. So it is not going to reverse any drugs. It's just going to hopefully stimulate them to breathe. So what you can do is, if you're in a room and the veterinarian isn't there, I would always err on the side of caution, turn them extremely down, start giving them oxygen. I mean, I don't usually start pushing fluids till my doctor tells me, but and then you have to watch them to see if they're going to wake up. Because like I said, I've had patients that have kind of scared me. They've gotten a little too deep, a little too close, and I've almost like completely shut them off. And then they start, their heart rate goes up, they start huffing and puffing. I start to maybe see their paw, and then I turn them back up. I'm like, okay, I got you back. I'm going to turn you up, but I'm not going to like, you see what I'm saying? It's no one should ever feel intimidated to somewhat wake a patient up or have them get light and have a doctor get mad at you because, you know, you're erring on like, we got to get this patient awake. That's probably what's safer. Okay, sorry. Pale mucous membranes, you know, you always have to get an idea of their mucous membranes unless they're aggressive or they're a little exotic where you can't see. You really need to make sure you know their mucous membrane going in, because if they get pale during surgery, did they come in pale or is this a new problem? Most often, you know, patients that are pre-existing anemic are going to be pale. But if it happens during surgery, a couple of reasons. They could have lost blood. So, you know, check with your surgeon and like, is there excessive bleeding? Because my patient's getting pretty pale. I mean, I'll literally just tell the doctor, like, sometimes I say, what does it look like in there? Because my patient up here is pale. I need you to tell me what's going on in the abdomen. And I'll be as frank as that with the doctor and say, what's the problem? Some agents, like high dose acepromazine, or if a drug like dextromethorphan, maybe you guys have seen this in radiology, when you give a dextromethorphan, it causes a massive vasoconstriction. Those vessels get very small. So what happens is all of the blood flow to the periphery, and I've said this about 500 times, peripheral blood flow gets centralized. So when you look at the gums, they look pale because all that blood got sent to the core. It's not that they don't have it. They still have that blood. It's just not in their periphery. It's in their core. So dextromethorphan patients will look pale, but that is an effect of that drug. If they didn't get that drug, then I'm concerned. And obviously, if they're hypothermic, then they're going to get pale because hypothermia causes vasoconstriction. So when I see this, you know, the first thing is my patient too deep. And I look at my pulse, I look at my blood pressure. And again, the attending veterinarian, I will literally be like, hey, Dr. Ritz, my patient's pretty pale. Is everything okay in there? Sometimes the doctors get so focused in the surgery and they can be having problems and they have to focus. They're doing surgery. But sometimes they don't always tell me, hey, by the way, like I'm having a bleeding issue that I'm trying to fix. So is there any drugs that have caused this? Do we have to give fluids? Tell your doctor. And if they have a CRT, now normally CRT is always less than 2 seconds. So this is the little alligators going the other way. So this means greater than 2 seconds. So if it's 2 seconds or longer, then usually what's happening is I'm concerned that blood pressure is not getting to that area quick enough to refill the capillary refill. When I push it, all the blood gets pushed out of the capillaries when I push on the gums. When I let go, blood pressure should fill those capillaries back up in a certain amount of time, less than 2 seconds. So now it can be, was the animal in shock before surgery? Are they losing blood? That'll affect CRT. And if they're too deep, so if, you know, they're excessively deep. So if I'm the anesthetist and I'm seeing this prolonged CRT, I need to check the pulse and the blood pressure. Are they tachycardic, bradycardic? I can try to feel a pulse. Remember, a rule of thumb is if you can feel a pulse, if I can feel a femoral pulse, it has to be at least higher than 60. If their blood pressure mean is below 60, theoretically you cannot feel an adequate pulse. So that's kind of a guideline. You know, obviously you need to get a real blood pressure, but in a pinch, can you feel a pulse? If you can feel it, technically it should be probably at least 60 or higher. And then, are there any other signs of shock, hypothermia, tachycardia? Now, an animal in an early shock has a very high heart rate, and then it can drop if the patient's starting to bottom out. So, you know, it can go from tachycardic to bradycardic, but you have to look at all that. And again, clue in your doctor, because maybe there's a bleed that they don't know about. You pick up on the fact that you have a pale mucous membranes and extended CRT, and then all of a sudden they start looking in the belly and they see, oh, look at all this blood. So sometimes it's going to clue them in that there's a problem on their end. So you got to communicate and never be intimidated to say something. Okay. Now, hypotension, which is low blood pressure, the very first thing that I think of is that they are too deep. I will tell you, the most hypotensive agents we use are isoflurane and sevoflurane. Worse than any of the injectables that we use. They are the most hypotensive agents. Next would be acepromazine. Next would probably be propofol. So those drugs tend to lower blood pressure. Now, if it lowers it a little bit, I mean, blood pressure is going to be lower. They are anesthetized. Okay, so anesthesia lowers blood pressure. It's just that we don't want it to get too low. Okay, a drop is going to be somewhat normal. We just don't want it to be excessive. So we got to watch. If I'm worried about hypotension, like if I have a patient in shock, if I'm worried because of their kidney function, I really want to watch blood pressure. So minimize use of drugs that cause vasodilation. Now, I like propofol. If I want to use it, I might use a low dose. If I want to use ACE, I'm going to use a really low dose. So it's not that you can't use those drugs with an animal with hypotension, but you're going to use them cautiously. 10 to 20 mils per kg per hour. I believe surgical maintenance you guys are using is 5 mils per kg. So this would be double or 4 times surgical fluids. Now that's up to the doctor. Doctor always gives me my fluid rates. So I'll say, do you want me to push fluids? Do you want me to increase fluids? And they will tell me. Now, I have kind of steps to blood pressure. First thing I do is I try to turn down my gas, because most of the time your gas is what's causing they're being sensitive to isoflurane. So if I have them at 2, I might turn them to 1.5. If blood pressure doesn't improve, I try to increase IV fluids. I might give a fluid bolus where I calculate a dose of fluids and I run it at 999 really fast, and then I move them back down to their surgical fluids. If a fluid bolus doesn't work, then I may want to add a colloid, because if they are hypotensive or they have an underlying condition, sometimes they have leaky vessels. It's kind of like you're putting in fluids and then they're leaking out. Well, remember, a colloid is a big molecule, and an LRS fluids is going to bind, and then it's going to keep the fluids and should boost my blood pressure. Okay, so turn down your anesthetic, consider IV fluids. You may have to get pain meds to turn down the anesthetic. Consider colloids. Our last resort is there is a group of drugs called positive inotropes. There's a drug called dopamine, which is DOPAMINE. Now, dopamine is not one shot. It's a drug we have to put into a CRI and put them on a drip. But dopamine is called a vasopressor. Vaso meaning vessel, pressor. And what it does is it increases the tensions in the vessel, which should increase your blood pressure. But again, that's not my first choice. I try to, a lot of times just turning down the anesthetic maybe giving some fluids, maybe giving some pain meds so that you can turn down your anesthetic. A lot of times that can do the trick. And always double check your cuff. So I will tell you, those automatic cuffs are sometimes inaccurate on cats. They don't give good blood pressure readings. And everybody likes to say, oh, it's the cuff. Change the cuff. Do you get the same reading? Put it on a different limb. Sometimes you just put it on really in a crappy spot. Sometimes, oh, and I will tell you, if you use a cuff that is too big for the limb, you're going to get a falsely low blood pressure. So most of the time, your blood pressure machine comes with different sizes of cuffs. And remember, I said there's a little range on the cuff. And if you lay the limb, it should fit in between that range. Then you know that that cuff is appropriate. So make sure you check your cuff. But there's kind of a steps to go through. And then let's talk about dyspnea or cyanosis, which is significant if we're anesthetized, which means they are not getting oxygen. If they're having difficulty breathing, abdominal breathing, choppy breathing, we have to think about they're intubated, they're on 100% oxygen. Where is the problem? So, you know, if they're too deep, remember I said when they get excessively deep, sometimes what happens is the diaphragm starts to take over respiration, and the respiration looks different. The character looks different. It's choppy, and it's a very strange respiratory pattern. So if they're too deep, you can see this. If you ran out of oxygen, okay? So what do we have to do to start checking at this? I always start at my source and work my way to the patient. Do I have oxygen in the tank? Is the tube kinked? Is there a clog in the tube, like a mucus plug? Did I check the tube placement? Did I put the tube too far? And then what I start to do is I start to bag the patient with either a low ISO with oxygen or turn off the anesthetic. Does bagging help? And it should. I mean, theoretically, if they're too deep or they just weren't breathing enough, if I breathe for them and they start to pink up and my SpO2, so remember 95 and up is normal SpO2. In this situation, we see SpO2s in the 90s. And remember, 85 is my absolute. If they go below 85 on a pulse ox, that is an emergency. I'm very concerned at 90. I'm massively concerned at 85. Then you have to intervene. You got to bag them. You got to maybe change the tube, check your oxygen, check all of this. Now we may, if we are thinking this is heading towards cardiac arrest, we have to be cautious. We may have to get emergency drugs ready. This is a patient that I'm kind of prepping that we may have to intervene, okay? Because they're not going to be able to go too long without adequate oxygen level. That's for sure. Okay, so when we get into abnormalities with the heart rate, we usually break it down. Does the patient have tachycardia, bradycardia, or are they having an arrhythmia? Now, arrhythmias can also be classified as a tachyarrhythmia and a bradyarrhythmia. So how do we respond? If it's tachycardia, these are some guidelines that I'm not making you really memorize these numbers, but if you have a big dog with a heart rate higher than 140, 200 in a cat, sometimes this can come from drugs. So this can be, can happen after atropine, can happen after ketamine. Was the patient tachycardic to begin with? Sometimes can happen because of pain, but definitely we need to alert the doctor. Arrhythmias can happen if we have low oxygen, like a low pulse ox, acid-base imbalances. Do they have any myocardial, which is the muscle, damage? Sometimes patients with hypertrophic cardiomyopathy have arrhythmias because they get poor oxygenation to the heart muscle. Sometimes traumas have myocardial trauma from a hit by car. So we may have to, on a physical exam, unless you hear an abnormal rhythm, and not every patient gets an EKG, but if they have a trauma, they should have an ECG. If their heart rate seems abnormally fast on a physical exam, you should do an ECG. And sometimes the heart arrhythmias go along with pulmonary disease, so that definitely has to be looked at. Tachypnea is if they have a very fast respiratory rate, and you would pick this up by listening to the respiratory rate, counting the breaths with the chest. Is it because of a too high CO2? Is it because of pain? Now, sometimes if they have a fast respiratory rate, but blood pressure is good, oxygen's good, CO2 is okay, you can try to turn them up, but you have to make sure, why are they tachypnic? So it says, if your body temp's good and vitals are good, you don't want to rapidly change the vaporizer. You have to look at your other values. If it seems like it's during the middle of the castration or the middle of the painful part of a procedure, again, sometimes if they're tachypnic and they're painful, a lot of times if they're painful and tachypnic and they usually have a tachycardia, you may want to give them some more pain meds, hydromorphone, butorphanol. But again, I explained obese patients tend to have a tachypnea because they have trouble ventilating, and you just may have to assist them more. And sometimes turning them up isn't going to help. Sometimes it's because they are truly obese. Now, bradycardia, it's really going to depend. It says a heart rate less than 60 to 70 in a dog, except, if that's a Great Dane or a big German Shepherd, 60 to 70 isn't a bad heart rate. So I usually say, what was their TPR heart rate, physical exam? And if it's dropping close to 50% of that, so if it was 120 and now it's 60, that's bradycardia. But if it was 120, now it's 80, it's lower, but to me, I don't consider that bradycardia. So this can be drugs, dexdomitor, vagal stimulation, they're too deep. Sometimes because the other thing is when an animal has a super high blood pressure, the heart rate drops. That's why dexdomitor causes a jump in blood pressure when you give it. That's why the heart rate goes down. It's a physiologic response. So sometimes the anesthesiologist, and he taught me this, is if the heart rate was low, he's like, what's the blood pressure? Blood pressure's great. What's their color? Color's good. Parameters are good. He says that I'm not worried about it. The job of the heart is to pump enough blood to maintain blood pressure and perfusion. So if we are meeting adequate blood pressure and adequate perfusion, do I need to treat the heart rate? Okay, so the goal is not necessarily a magic number, but is the heart achieving its job? And that's why you have to look at your other parameters. Can be hyperkalemia too. So if they have a high kalemia is potassium. So if they have a high potassium, sometimes they'll be bradycardic. So make sure they're not too deep. Make sure you don't have them turned down. You can reverse them if the doctor is concerned that it is too low. Now, cardiac arrhythmias, there's a variety. You've done this in Tech 4, so you should have gone over arrhythmias. And that should be ECG, not UCG. But this could be VPCs. It could be what's called ventricular tachycardia, where It's a specific tachycardic rhythm. Um, Sometimes it comes from arrhythmogenic drugs. Alpha 2s cause bradyarrhythmias like heart block. Sometimes ketamine causes tachyarrhythmias. So did you use a drug that caused it? A lot of times when you give atropine, when you first give it to a patient, sometimes they'll drop their heart rate initially and go into some heart block before it speeds up. So sometimes it's seen initially with atropine, ketamine, and xylazine. Um, and this is going to be up to the doctor because the treatment depends on the arrhythmia. So you're going to want to like look. So what I do if I have a patient with an arrhythmia, make sure oxygen is adequate, make sure they have a good SpO2, try to ventilate them because sometimes VPCs come from hypoxia or low oxygen. So sometimes ventilating the patient fixes the problem, and that's all that's needed. So sometimes we're going to ventilate them. Lidocaine is a drug that will treat runs of VPCs, but that will be up to your doctor. But what you need to do is look at your patient's QRST complex, look at the heart rate, and look at the blood pressure and assess. Apnea is a temporary cessation of breathing. Sometimes it happens after you give a drug like propofol. Propofol and Alfaxin, if you give it too fast, will cause them to stop breathing briefly. 3 to 5 minutes breathing should come back. I intubate them and I breathe for them. Sometimes it can be that they're excessively deep. So what I do is if they are apneic, I'm going to support their ventilation, check their SpO2, make sure it's not affecting saturation, and check their blood pressure. So again, here, if a patient may not require treatment, if the heart rate is regular, pulse is strong, SpO2. So you see what I'm meaning? If you can't just look at one thing, again, if it's from propofol, it's going to go away. Breathing is going to reestablish. So you just need to support them until. Now, if you have a patient at 4% isoflurane and they go apneic and they're bradycardic and they're pale, you have a patient that's too deep. So you have to look at all of your parameters. And the difference between apnea and respiratory arrest is then respiratory arrest is they've completely stopped breathing. So if apnea has gone on for too long and they're very, very deep, they could have respiratory disease or you ran out of oxygen and they stopped breathing. This can be fatal. So what I start to see if a patient, if I worry about respiratory arrest, that bradypnea, the respiratory rate's going down, down, down. You start to see a change in character. So the way they are breathing is different, more abdomen. May start to see some bradycardia. So what you need to do is you need to try to ventilate them and also alert your doctor, say respiratory rate's dropping, had a problem with the oxygen. Now, I'm talking about patients that are anesthetized. So we are going to assume that the patient is intubated. But if this was like a sedation, then you need to establish an airway and start breathing. When we talk about the A, B, C, D, E's of CPR, airway, breathing, chest compressions, drugs, EKG. So we kind of do things in that order. I mean, the first thing you have to do is establish an airway. But let me tell you, if I think my patient has respiratory arrest or I'm worried about impending cardiac arrest, the very first thing I do if a patient is on gas, turn off the anesthetic vaporizer. Everybody needs to know that because if you start trying to intubate or trying to check the tube and check your oxygen and get fluids and get emergency drugs, your patient is continuing to receive anesthetic. You have to stop anesthesia. So the very first thing is to turn off the vaporizer and then get everything done. Make sure you have an airway, make sure it's clear, make sure you have oxygen, make sure you check your tank, make sure, reverse any drugs. And what you want to do is you want to start breathing for the patient completely about once every 3 to 5 seconds. So there's a common, you guys will go over CPR in Animal Tech 5, but there's the song Staying Alive. Staying alive, staying alive. I'm not singing it very good. It's late at night. That's about what you do chest compressions. I usually, if I'm the person breathing, about every 3 to 5 compressions, I give a breath. So if they're like 1, 2, 3, 4, 5, 1, 2, 3, 4, 5. So you're going to time it about so you have to be somewhat coordinated with the person that's doing CPR. And again, if the patient has not went into cardiac arrest, you're still going to ventilate about every 3 to 5 seconds. Make sure that we reverse any drugs. Make sure we can give IV fluids. Try to keep the patient warm. If you are not hooked up to a machine with oxygen, then you can use something like this called an Ambu bag. And what this does is it hooks up to the endotracheal tube and it pulls in room air. So this is not oxygen, this is just room air, but you're still ventilating the patient and expanding the lungs. So again, if you do not have access to a machine with the bag with oxygen, then this is what, most emergency carts should at least have an Ambu bag so that you can ventilate the patient. Okay, let me skip. Well, let me just talk about this a minute. So cardiac arrest is obviously when the heart stops. And a lot of times, I have told you guys, the ECG may start to look strange. I've had patients very close to arrest, and the way I can describe the ECG starts to get wide and bizarre. It doesn't look like a normal PQRS, or it looks like a very wide PQRS, and that can be impending arrest. And a lot of times, cardiac arrest will happen first, and then respiratory arrest, and a lot of times very close together. But this would be, you don't hear a heartbeat anymore. Your blood pressure reading is dropping to 25 or lower, which you're not really the heart's not really pumping. And the mucous membranes can either look purple or they look gray because there's no circulation. And then the telltale sign for me is the eyes. The eyes are central and they're dilated, and there's no corneal reflex, there's no palpebral reflex, and there's no pupillary light reflex. And what you see sometimes is, instead of, which is these abrupt gasps, is called agonal breathing. So the animal is not truly breathing. The diaphragm, or the brain, it's like a last ditch effort. It'll trigger the diaphragm to go up. And they're trying to initiate a breath. It's kind of like an agonal breath. So if you start to see that, that's a concern. Start to see their jaw go. It's probably not that they're swallowing, it's that they're starting to go agonal. So there's cardiac arrest is the heart. Respiratory arrest is just not breathing. And then you can have cardiopulmonary arrest, is where there's no breathing and no heartbeat. And at this point, generally to be safe, or to not to be safe, to be successful, you have about 5 to 10 minutes to try to get the heart beating again, to bag the patient, because that lack of oxygen to the brain is going to cause permanent death. So this is when everybody kind of has to snap into a job, and there is a new kind of initiative called Recover Initiative, but it's basically reassess campaign on veterinary resuscitation. So they started looking, it used to be the ABCDEs, but there's been a lot of research on CPR and what's successful. You don't need to know these abbreviations, but we're going to talk about basic life support actions and then advanced. Ideally, you need at least 3 people. You need someone breathing, someone doing CPR, and someone giving drugs. Ideally, if you have a 4th person, they assist. They might put some abdominal pressure to help with blood flow. And this is when you probably want to start to, practice this in a non-emergency setting. So here we look at, you have an unresponsive, they're not blinking, not breathing. We're going to start potentially chest compressions, and they show it's hard on here to do, different ways, but best is to put them in lateral recumbency, left lateral if you can, but if they're on their right side, you just do it. And then someone is going to be breathing, and someone needs to start, get them on an EKG, someone needs to start listening. Are we hearing any heartbeat? Are we picking up anything on an EKG? Hopefully you have, hopefully you have venous access. But let's break it down. So if a non-responsive patient, you have to really figure out. So you put in a stethoscope, you try to feel for a pulse, you try to put your hand on the chest, and you might have to say to someone, I don't hear the heartbeat. You may just have to be that abrupt. Then chest compressions. I happened to be talking to them during that neuter. As soon as Mrs. McClure had the stethoscope, she's like, I don't think I hear the heart. And I went in there and I looked at the EKG and it was flatlined and I could not feel a pulse. So I immediately started pushing on the chest. Now at that point, Dr. Ritz was still in surgery. The dog was on its back. So I was just doing chest compressions from the sides, but eventually we had to get him turned over. Now the dog was already intubated. So she started breathing. I started doing chest compressions. I asked for help. And then the other instructors came in. Dr. Paul started getting drugs. We all took turns doing compressions because it's very physical. It's very hard to do. So what you want to do is placed on its right or left side. And your two-handed technique at 100 to 120 beats a minute. Sometimes people go too fast. But think about the average dog, about 100 to 120 beats. And the other thing that you want to do if you have help is do something abdominal compressions where somebody is, let me see, I think it's on the next picture. So this is showing on a cat. You can do with a hand or 2 hands. But the other thing we do is somebody, if I'm pushing the chest, when I stop, the other person pushes the abdomen. It's called abdominal counterpulsion. And what we're emulating is circulation. So when I push, because remember, this heart is not beating, you have all this blood in the back half of the animal. It's got to make its way forward. Okay. So this just shows, and then if you absolutely didn't have an ambubag or an endotracheal tube, you would hold their mouth closed and you would breathe into their nose. So this is, good first aid for, you're outside walking your dog and God forbid something happens. So basic life support, get them intubated, ventilate them with 100% oxygen, somewhere about 10 breaths a minute, which is about 1 breath about every 3 to 5 compressions. So you alternate. And the person doing the compressions does not stop for me breathing. In fact, they've said research, it's better if you push the heart when you're compressing the lungs, because what it does is it helps push blood flow. So I actually try to time my breath with their fifth compression. So I do it at the same time. That way it helps. Now, when we get into advanced life support, this is when we're going to try to do some other methods. Now, this again is if we think we're getting them back, we're starting to see a sign, have someone do ECG leads. Now, you don't want to stop everything to put on an ECG, but if you've got that extra person, put on an ECG. There's a reason they say not to use alcohol, because now the only time you do this is if you have a defibrillator, which not a lot of places have. But if you guys have watched Grey's Anatomy and they do the paddles and they put the gel and they go clear, that's an electrical shock. And if they come into contact with alcohol, it can set the patient on fire. But again, unless you're working in a very high-end referral surgery ER, most of the, and we had a defibrillator at Purdue. I don't even think we had one at VCA. So not a lot of places have a defibrillator. So you're going to hook up a capnograph, because a capnograph is excellent to pick up if circulation is successful. If you are getting circulation, you will get blood flow to the lungs and you will see a CO2 tracing. Get vascular access. Place a catheter. Hopefully your patient has a catheter. You can put it intraosseous if you have a very pediatric patient or you can't hit a vein. If you absolutely can't get any access, you can put emergency drugs down the trach tube. You have to double your dose. So, because a lot of that drug is going to be lost in diffusion through the lungs, but you would squirt the the atropine or the epinephrine down a tube and then give them like 3 or 4 good breaths to kind of blow the drug into the lungs. But that's only if you can't get a vein. This is very controversial, whether you should put an injection directly into the heart. An extreme last-ditch effort, but you can cause damage, so that's not generally recommended. And again, at this point, starting compressions, breathing, getting drugs on board, making sure you have a tube is first, and then also, can we reverse anything? Again, that dog had dexdomitor, so we gave antecedent to try, because if this is an overdose or a reaction, can we get that drug out of the system? So if you can reverse the opioids, if you can reverse the alpha-2, definitely in the middle of doing emergency drugs, you want to do that. The other thing is you want to change people that are giving compressions, because people are going to get tired. So 23 minutes, the other day there was 5 or 6 of us in there. We were maybe going like not even 5 minutes, and we were switching out. And you definitely want to give people a break. Okay. And then periodically when we switch people compression, we stop and we look at the EKG. So it is definitely useful to have an EKG to see, is any cardiac activity returning? So, and let me go back for a minute. So you take a break, we reevaluate. Do you detect a pulse? So somebody feel a femoral pulse. Do we have return of circulation? Do we not? Do we have any ECG? Is it a normal ECG? Can we hear a beat? Do we pick up any CO2? So we're continuing to, assess whether we're close to getting them back. If we do confirm that we have circulation, we have a pulse, we hear a heartbeat, we would obviously stop. We would continue advanced life support like fluids and ECG. If you get a dog back after CPR, they're definitely probably going to be on an ECG continuously. maybe oxygen support, IV fluid support, because, they just went through a traumatic event. And then, are they breathing adequately? You may still have to supplement them. And then, again, I've already said, administer the reversal agents. If we get the animal back, you want to get all the drugs out of the system if possible. Okay, actually, I'm going to stop the lecture here. And this test will just be over everything up until CPR. I'll explain more on Friday. Okay?